Okay, today we're going to be talking about gas exchange. Our exemplars are acute respiratory distress syndrome, anemia, pulmonary emboli, and cystic fibrosis, which will be covered in future PowerPoint presentations. And next we're going to kind of look at our gas exchange diagram and thinking about it in relationship to these four disease processes. So gas exchange is the process by which oxygen is transported to cells and carbon dioxide is transported from cells. So the attributes that we're going to assess for is we're going to look at their respiratory status, is it within normal limits, how fast are their respiratory rate, what their pH is on a blood gas, what their oxygen saturation is, how much oxygen they're on to maintain that saturation, the dissolved oxygen, the PaO2, the dissolved carbon dioxide, PaCO2, and end-tidal CO2. We're also going to see, is the patient awake, alert, and oriented? Are they confused? Because obviously if they're not getting enough oxygen to their brain, they're going to have a change in level of consciousness. We're also going to look at skin color and is it appropriate for this person to be that color? And then we're going to look at the antecedents, which is, what is adequate functioning of the respiratory system? If I'm breathing right, am I perfusing everything? Is those red blood cells carrying my oxygen to those tissues? Is my heart moving those red blood cells around adequately? Is the oxygen I'm breathing into my lungs actually getting exchanged with the carbon dioxide? Does this patient have adequate neurological function, and does the patient have efficient cellular metabolism? So some sub-concepts with our concept of gas exchange would be inhalation and exhalation, oxygen carrying capacity, which would be our red blood cells, and circulation. Some interrelated concepts to look at is mobility. How is your patient moving? What happens when your patient doesn't move? Coping, whether it's a long-term disease process or an acute respiratory distress syndrome, where it's a short disease process but can have a life changing effect on the patient. Acid-base balance, how does that relate to our exchange of oxygen and CO2? Perfusion, how is our body moving things around, how moving those red blood cells around, and nutrition, and how does that affect the building of red blood cells? How does that affect our patient with cystic fibrosis, and how does that affect our patient with acute respiratory distress syndrome? And then consequences. Our positive consequences would be normal respiratory status, normal respiratory rate, that they would be moving appropriately and getting around, circulating that blood, that they'd have good capillary refill, and that they are neurologically intact. The negative things would be the respiratory compromise, respiratory distress, and respiratory failure. Altered oxygen carrying methods, which would be anemia, and hypoxemia, altered mental status because they're not getting enough oxygen, and what happens with anoxia, and then VQ mismatch, and what does that mean for our patient? Okay, so the objectives, I'm not going to read them for you. You can read them. They're also in your syllabi. So let's start with a respiratory and review here. So the three systems that work together to provide oxygenation and tissue perfusion are the lungs, the heart, and the blood vessels / red blood cells. The lungs obviously will intake our oxygen. The heart will pump to move that oxygen around. The red blood cells will carry the oxygen to the cells, and the carbon dioxide will be carried back to the lungs by the heart, via the heart, and exhaled in our lungs. And the body maintains a balance. So you can see this picture is on a teeter-totter. So when one thing is out of balance, it can cause the body to try to compensate for any inadequacies. The body likes homeostasis, and it will do its best to keep up with that process and maintaining that homeostasis environment. The problem becomes when our body can't keep up with that, and then the patient starts to suffer with oxygenation and tissue perfusion. This is a picture of the alveoli. This is where gas exchange occurs. Oxygen and carbon dioxide are loaded and unloaded onto the hemoglobin. There are about 290 million alveoli per one healthy person's set of lungs, and it makes a very large surface area for gas exchange to occur. If you unrolled all the little alveoli in your patient's lungs, the surface area for that patient's lung would be the size of a tennis court. So it takes a lot of surface area to exchange gas, to exchange the oxygen and the carbon dioxide. Some terms to remember when we think about some of our oxygenation problems and gas exchange problems. Hypoxia is decreased tissue oxygenation. So the tissue is actually not getting enough oxygen. Hypoxemia, low levels of oxygen in the blood. Hypercarbania, high levels of carbon dioxide in the blood. Surfactant is a fatty protein that reduces surface tension in the alveoli. Again, that's a fatty protein that reduces surface tension in the alveoli. So the higher your surface tension is, the harder it is for oxygen and carbon dioxide to exchange. And lastly, atelectasis is the alveolar collapse. The surface area is reduced, causing ineffective gas exchange. So that occurs because our alveoli stick together and collapse, and when they're closed, no gas exchange is occurring in that alveoli. Okay, oxygen toxicity is another definition to go revisit. Oxygen toxicity occurs when O2 or oxygen levels are kept at greater than 60% continuously for more than 24 to 48 hours. And when I mean oxygen levels, I mean oxygen levels that are being administered to the patient. So if you have them on 100% non-rebreather, then they're getting oxygen at 100%, or Venimask at 60% or greater. So prolonged exposure to high levels of oxygen damages our lung tissues. The effects of oxygen toxicity can cause increased pulmonary capillary permeability. So the things coming out of the pulmonary capillaries can actually leak into the alveoli space, decreased surfactant production, and actual fibrotic changes in the alveoli. And so when the alveoli become fibrotic, they can't expand. They get very stiff, and it's hard to ventilate the patients. So some clinical manifestations are very similar to acute respiratory distress syndrome, which we'll talk about in the future. Atelectasis, pulmonary edema, which would be that leakage from the capillary membrane, hemorrhage, and hyaline membrane formation, which is actually a membrane that forms around the alveoli, which decreases the ability for gas to exchange between the red blood cell and the alveoli. All right, so acute respiratory failure. You have your two kinds, hypoxemic respiratory failure, hypercapnic respiratory failure. You can have both of these syndromes that will affect your acute respiratory failure. So what is acute or hypoxemic respiratory failure? It is partial pressure of arterial oxygen less than 60 on 60% oxygen. I'll say that again. Hypoxemic respiratory failure is partial pressure of arterial oxygen less than 60 on 60% oxygen. So they're receiving 60% oxygen, and their blood gas still indicates that their PaO2 is at 60. So PaO2 level in respiratory failure indicates there's an inadequate oxygenation saturation of the hemoglobin. So that's one cause of our hypoxemic respiratory failure. Another indication is that patients' PaO2 levels are dropping despite giving the patient 60% of oxygen or more. So there's a reason that even though we're giving them oxygen, they're still not able to perfuse or exchange that oxygen or perfuse their body, because either they don't have enough red blood cells or they have a disease process going on in their respiratory system. Hypercapnic respiratory failure, the definition is partial pressure of arterial carbon dioxide more than 45 with acidemia. So partial pressure of arterial carbon dioxide more than 45 with acidemia. So acidemia would be a pH less than 7.35. And it is defined as a PaCO2 number that is higher than normal, so greater than 45. Another evaluation tool is the assessment, and the diagnostic evaluation indicates that the body cannot keep up the pace for the increased CO2, so the body is trying to compensate to blow off the extra carbon dioxide, and eventually your patient will just wear out and get too tired to breathe. You see that a lot with patients with COPD. They are unable to blow off the CO2, and so they have an increased respiratory rate. They're using their accessory muscles and putting in all this respiratory effort. Eventually, they will grow tired, and they will not be able to keep up the pace to blow off that CO2, and so the CO2 will rise. The patient will become lethargic and unresponsive, which will further diminish the patient's ability to blow off that CO2, and either you put them on the ventilator or they could go into cardiac arrest. And so that's how a patient with COPD can end up in respiratory failure. And lastly, hypercapnic respiratory failure is indicated that the pH is at a level where further decrease may lead to severe acid-base imbalance. So now our CO2 is at 105, our PaO2 is at 58, and our patient is tired and not breathing well and lethargic and maybe even comatose, and I bet their pH level would be at like a 7.16 or something. So the best way to reverse that is actually to probably intubate that patient at that time and help them breathe off some of that CO2. Many times patients have both types of these respiratory failures. So let's talk a little bit more about hypoxemic respiratory failure. So that is patients PaO2 at 60 or lower despite being on 60% oxygen. So let's talk about VQ mismatch. So V stands for ventilation and Q stands for perfusion. In normal lungs, the volume of blood perfusing the lungs each minute is 4 to 5 liters. This is approximately equal to the amount of gas that reaches the alveoli each minute. In a perfect patient, each portion of the lung would receive 1 milliliter of air for 1 milliliter of blood flow. This would match ventilation breathing in and out of lungs to the perfusion heart pumping blood to a 1-to-1 ratio. So mismatch occurs when things aren't 1-to-1. So example of mismatch would be, for ventilation, would be a COPD patient. Perfusion is normal, the patient's heart is beating, it's pushing blood around, the patient's not anemic, but the patient is unable to ventilate well. Perfusion mismatch example would be a pulmonary embolism. Ventilation is normal, the patient is breathing in and out, but the perfusion to the lung is poor because there's a blood clot in the way. Shunt is another type of VQ mismatch. Shunt occurs when the blood leaves the heart without having participated in gas exchange. It is extreme VQ mismatch. Anatomic shunt, an example of this would be an anatomic shunt, which would be a ventricular septal wall defect. So the patient's actually skipping and bypassing the lungs, just pumping the blood from the right ventricle to the left ventricle. Interpulmonary shunt would be ARDS. That is where your body is not able to exchange the oxygen and the CO2, which we'll talk a little bit later in ARDS. Patients are typically very hypoxemic with this type of VQ mismatch, and oftentimes they need ventilator support and high levels of oxygen to improve gas exchange. Another type of ventilator and perfusion mismatch is diffusion limitation. This occurs when the alveolar capillary interface is compromised by a process that thickens, damages, or destroys the alveolar membrane, or affects the blood flow through the pulmonary capillaries. You see this with patients with severe COPD, patients who have pulmonary embolism, patients who have pulmonary fibrosis, and patients who have acute respiratory distress syndrome, or ARDS, ARDS. A classic sign of diffusion limitation is when a patient becomes hypoxic with activity but is fine during rest. And our last type of hypoxemic respiratory failure VQ mismatch is alveolar hypoventilation. This is decrease in ventilation causing an increase in carbon dioxide and a decrease in oxygen. Patients who suffer from this often have a central nervous disease such as like Guillain-Barré or ALS. Somehow their diaphragm is not functioning as well as it should, or some kind of spinal injury. They might have some chest wall dysfunction. So if they have a pneumothorax, they could have alveolar hypoventilation. Asthma, a restrictive lung disease. So that would be like COPD or pulmonary fibrosis. And this slide here is actually just a picture to kind of help you think about when you're thinking about VQ mismatch, the different types. So A is a shunt. You can see in the picture that there's tons of secretions there. The red blood cell, the oxygen can't get down to the alveolar area to exchange the oxygen and the CO2. It's completely blocked. So the blood is bypassing the lung without getting oxygen at all, and the lung is still oxygenating, but it's just not, that exchange is not occurring. B is VQ mismatch, the ventilator and perfusion. So in B, the patient's breathing normally, but you can see there's a mucus plug in the way, so the oxygenation is not as much as it should be, even though the heart is pumping just as normal as it always does. C is normal VQ, so normal mismatch, or normal ventilation and perfusion, not mismatch, excuse me. So C, you can see all of the oxygenation is getting down and perfusion is going round and round. D would be an example of VQ mismatch in which the patient is oxygenating well, but you can see that they've indicated a clot, and so it's being poorly perfused. The patient can't pump blood into those pulmonary capillaries, so the patient's still breathing the oxygen in, but the blood is not picking up the oxygen and exchanging the CO2 there. And lastly, E is dead space, no perfusion, meaning that there's a clot or something. So you can see the lung is breathing in the oxygen as it should, but there's no blood flow in the vessel there. And so the patient is not exchanging carbon dioxide and oxygen. Okay, our next topic will be ARDS, so I'm going to move to that slideshow next.